But yeah, good morning, everybody. Welcome to Sleep Medicine Grand Rounds. Today we have Dr. Marvin C., one of our own, and a neurologist and a sleep physician who is based out at Portage Medical Center and is a senior attending physician here at University Hospitals. Dr. C is going to be talking to us today about REM behavior disorder and neurodegeneration and, its association with sleep apnea and beyond that.
Yep, good. Can you guys hear me well? Okay. All right. Well, good morning, everybody, and thank you to Sushil in the sleep section for the invitation to give this grand rounds. So I've been with University Hospitals for almost actually 6 years now, and been an attending for about 11. The title of my talk today is Sleep Medicine Beyond Sleep Apnea, RBD and Neurodegeneration. I wanted to highlight the part where it says Sleep Medicine Beyond Sleep Apnea, because in as much as, sleep apnea takes up the majority of the time in the sleep clinic, there's actually other things other than that, at least the sleep providers, physicians, fellows, and everybody needs to be aware of, at least. It's not working. Hold on. There you go. All right, so we're going to discuss a couple of things today. REM sleep without atonia and REM sleep behavior disorder, symptoms, diagnosis, and REM sleep without atonia. We'll discuss the association of RBD with neurodegeneration. And lastly, we'll explore controversies and ethical considerations in RBD diagnosis. I do not have any financial disclosures. I do want to say some non-FDA approved treatments will be discussed in this presentation, if only because there are no FDA approved treatment that exists for this condition, unfortunately. So we'll start out with a case of a 35-year-old male seen in the sleep clinic, referred by primary care for evaluation of daytime sleepiness, unrefreshing sleep, and sleep talking, abnormal movements. He kicks during sleep, kicks his wife, does not get out of the bed. There was at least one episode where he punched a wall and in the process injured his knuckles. He had screamed during the night during sleep, sometimes wakes up mid-sentence and remembers the dream. There's been no recent reported weight gain, cataplexy, or sleep paralysis. He's had a personal history of bilateral extremity tremor, left worse than right since childhood, not formally evaluated, and history of depression. He's had some family history of tuberous sclerosis and epilepsy in his sister. His medications included amitriptyline as well as duloxetine with recent dose increases. His exam, he is non-obese. His Mallampati is 1. Otherwise, normal neurological examination except for a slight postural tremor, left worse than the right hand with normal tone. So I wanted to start this with what is the presenting complaint here, or what is being presented to you, which is what sounds like dream enactment behavior, or DEB. This can be a chief complaint. Sometimes this is mischaracterized, as being sleep terror or perhaps nightmare. I always tell trainees, unfortunately, patients don't come to you with a label on their forehead that, I have RBD. That's really for you to be, diagnosing. So dream enactment behavior, this is not specific for RBD. Almost all, but not all patients with RBD will have a history of dream enactment behavior, and the few that do not are diagnosed purely by sleep study. This dream enactment behavior can be seen also in untreated OSA, sleepwalking, sleep terrors in adults, epilepsy, PTSD, or in alcohol or drug administration or withdrawal. So RBD belongs to, you guys are probably familiar with this. RBD belongs to the sleep category of parasomnias, specifically the disorders with REM sleep. Okay, parasomnias are undesirable actions, movements, events during sleep that we see sometimes in some patients. So REM behavior disorder, this is characterized by both abnormal REM sleep electrophysiology, which is REM sleep without atonia. Basically, you need a sleep study for that first one, and abnormal REM sleep behavior, which is a history of recurrent nocturnal dream enactment behavior that is historical or witnessed. Okay. RBD prevalence, what I've seen was it's about 0.5%, but this is of the UK population. I didn't quite see a number for the US. The timing of episodes usually reflect when the patient is in REM sleep, which means that it's usually during the latter half of the sleep period and tends to be in the few hours prior to the wake onset. Exceptions could be something like a condition like narcolepsy. And with this condition, patients tend to enter REM sleep frequently within an hour of sleep onset, or in conditions where there are increased REM sleep drive, such as sleep deprivation or perhaps untreated OSA. So the frequency of these episodes can vary, and it can vary from patient to patient. It can vary from night to night, weeks to weeks. Okay, without treatment, some patients might have this every night, sometimes several times a night. Sometimes, there's no more than one or a few nights a month. And it can also exhibit clustering, meaning a patient may have a couple, this week, may not have one for a few weeks, and then we'll have some again in, whenever. And unfortunately, RBD can lead to self-injury or injurious behavior to bed partner. And this is something that we need to be addressing and counseling patients and caregivers when they come in and this is suspected. So the demographics and phenomenology, usually male gender, age of onset typically between 40 to 70. There could be abnormal vocalizations, shouting, yelling, abnormal motor behavior, usually of the upper arms, punching, kicking, those kinds of behavior, altered dreamentation. Interestingly, with RBD, they typically involve a chasing or attacking theme, and usually with insects, animals, or other humans being the aggressors, and the patient being the defender. That's an interesting thing. I've never known why that is, but that's been what is reported. And the exhibited behaviors mirror the dream content. So it's literally acting out their dreams. And the behavior, as I mentioned, tend to occur in the latter half of the sleep period. So diagnostic criteria. So normally walking and leaving the room, the bedroom, is uncommon. The patient's eyes are usually closed. The patient is usually attending to the dream and not to the actual environment, which can, again, lead to injuries. The heart rate is normal in RBD, unlike in nightmares, wherein there is usually tachycardia and sympathetic activation. PLMs in RBD are often present without arousals during non-REM, which we can see with other conditions, right? But they can also continue into REM sleep, which is unusual in all other settings. And movements typically, more commonly, involve the upper more than the lower extremities. So this slide, I got this from ICSD-3, the diagnostic criteria for RBD. Again, historical repeated episodes of sleep-related vocalization or complex motor behavior. And ideally, these are documented by PSG to occur during REM sleep, or based on the clinical history of dream enactment, presumed to occur during REM sleep, And there's PSG evidence demonstrating REM sleep without atonia. And the disturbance is not better explained by another condition. So in other words, at least as far as ICSD-3 is concerned, a PSG is needed for definitive diagnosis of RBD. In terms of the AASM scoring manual, because it is a scoring manual, it just tells us how to score. It doesn't tell us how to diagnose. Scoring, and this is the latest version, by the way, and this is the one that I saw on the website, version 3 as of 2023. Scoring REM sleep without atonia is optional. But if you are going to score, there are recommended guidelines as to how to do it. We're not going to get into the details here, into the weeds, other than there are some that are scored by sustained muscle activity. This is the chin amplitude. And then there are some that are scored during using transient muscle activity. This is mostly in the limbs. And then you can also have a combination of both. I wanted to bring your attention to this note 3 at the bottom. It says based on SMGR. And, I spent some time looking this up, the SMGR criteria, which is mentioned in this ASM scoring manual. We'll get to that in, I believe, the next slide. At least with the ASM scoring manual, there are no prescribed minimum number of epochs showing abnormal muscle activity required. And the REM sleep without atonia can be completely, patient is asymptomatic, and it's an incidental finding in PSG, and the significance of this when we see this is unknown. Or sometimes if you have historical correlate, but with no PSG evidence, maybe because you cannot do a PSG, patient doesn't want to do a PSG, or even if you had a PSG, but maybe there was no REM sleep seen that night, then that's at that point, it's a clinical diagnosis of probable RBD. Okay, so we'll get to this SMGR. So SMGR, it's a Sleep Innsbruck Barcelona. It's actually a group. They evaluated the EMG activity with the SMGR montage. Okay, they used these muscles, basically the chin muscle, the forearm muscle, and one of the leg muscles, EDB. And they looked at other muscles, I think a total of 12. Some of them are bilateral. That's how they got to 12, to obtain normative values for the correct diagnosis of RBD for clinical practice. So these are the muscles they looked at. Okay, and again, many of them they used left and right. And basically what they looked at was with the mentalis muscle, they use 30-second epochs, and they use tonic EMG activity. So when there's more than 50% of the 30-second epoch with tonic EMG activity in the mentalis muscle, they scored that as basically high EMG activity. On the limbs, it gets a little complicated, because what they did was they split the epoch. An epoch is 30 seconds. They split it into 10. So basically a mini epoch is 3 seconds. And they scored each mini epoch as having or not having phasic EMG activity with this definition here. And also they looked at a combination of tonic and phasic EMG activity. So basically what they are recommending for the diagnosis of RBD in clinical practice is that we recommend using a PSG montage quantifying any. So it's either tonic or phasic EMG activity in the mentalis muscle, and also phasic EMG activity in the right and left flexor digitorum brevis It's interesting they use flexor digitorum brevis because there's, as far as I know, there's no such muscle. And in elsewhere in their report, it's actually flexor digitorum superficialis. So I wonder if it's actually a typo in the upper limbs with a cutoff of 32% using 3-second mini epochs. And to this montage, the addition of bilateral anterior tibialis EMG can be useful for the traditional detection of PLMs. This is their exact wording in their study. So, as some of you are aware, our regular sleep studies, there's the chin EMG lead, which is the mentalis, okay? And then we have the quote unquote leg EMG, which is usually the anterior tibialis. Okay, so we don't normally do the flexor digitorum superficialis. And this is why if you are looking for something like REM behavior disorder, abnormal movements, and you order quote unquote arm leads, so that's where the text usually will put them at. Okay, and again, usually with RBD, the upper extremities are involved with the movements more than the lowers. And this is just showing the numbers with 100% specificity for various combinations of muscles that they looked into, and also the individual muscles. So going back to that 35-year-old case, this patient had some mild OSA, PLM index was 9, microarousal index was 35. I'm gonna move some of my things around here, but this black area here, this is REM sleep. He is in non-supine position at that time, and there's actually not a whole lot of limb movements that were captured at that time. So I just wanted to show here for those in the audience who do not read sleep studies or may not be familiar with what we're looking at here. So the top, 6 lines are EEG leads. This is what we look at when we read sleep studies. Then you have the eye leads, then the chin lead here as labeled. Then you have the leg leads, okay? And the bottom ones would be the respiratory channels. So the leg movements, will look something like this, okay? And this is N2 sleep. The patient is on his right side, okay? So this is not quite normal because of the leg movements, which we sometimes see. Now, in REM sleep without atonia, again, this is a 2 5-minute screen here. So each R is actually 30 seconds. So this is REM sleep. And look at the legs. Okay, there's increased phasic EMG tone in the legs. Having said that, this patient has low chin tone. Okay, so that goes with REM sleep. This increased EMG tone in the legs may or may not be normal. Again, if you're going to use that SINBAR criteria, this is going to be flagged as high EMG activity. This is from a different patient. This is how normal REM should look like. Okay, the chin tone is quiet, low activity, and the legs are pretty much uneventful. There's no leg EMG activity there. Yet a different patient with REM sleep without atonia. This is clearly REM sleep here. The chin tone is increased. Now, this is obviously relative to the non-REM sleep chin tone. There is increased muscle activity in the arm and the leg. And actually here, the technician wrote down that the patient actually was talking. This is clearly in REM. Okay, so clinically, this is actually what we can see in something like RBD. All right, we'll just take a quick break here. This is from about 2 weeks ago in our neighborhood. All right, we'll continue. So diagnostic delay, unfortunately, it can be quite long. It's about 8 plus or minus 11 years. The bed partners usually play an important role in seeking medical attention. And there have been, publications as to how or why these might be underreported. For one, if you don't have a bed partner, then you might not know. And some of them, lack of recognition, there are some cultural taboos, or maybe it's attributed mistakenly to behavior from psychosocial stressors, or maybe there's a fear about reporting or assigning some other supernatural or religious explanation, or that assuming that it could be due to substance or abuse disorder. As mentioned earlier, the dream content, usually there's a higher percentage of dreams with at least one aggression. The patient is usually a defender. There's usually negative emotions. Animal representation is common during the dream. It's usually not familiar characters, and feeding or sexual elements are usually not observed. And interestingly, there's no increased levels of daytime aggressiveness in this patient. So even if they're like, let's say, punching and yelling and kicking during sleep, it doesn't necessarily translate to daytime aggressiveness. So causes of RBD. So there is, in terms of like trying to think through this, it's usually, helpful to divide it into isolated, or what we formerly was called idiopathic RBD, as well as symptomatic, or what we call secondary RBD. Okay, so isolated RBD, it occurs in the absence of any current known neurological or sleep disorder. However, it might only be idiopathic now, but the patient may develop neurodegenerative disease later. And again, patients don't come in with a label on their forehead saying, I have isolated RBD or I have secondary RBD at this point. So with the secondary RBD, it occurs in neurodegenerative disease, narcolepsy, other neurological issues, or sometimes medication. Risk factors identified. There have been a couple of publications that I've seen about this. There have been reported associations. Again, these are associations, not causation, with dyslipidemia, smoking, pesticide exposure, prodromal Parkinson's disease symptoms. There have been some previously unreported links with a positive family history of Parkinsonism or dementia and carbon monoxide poisoning. There have been some gene studies that reported variants in glucocerebrosidase, conferring an increased risk of isolated RBD and Parkinson's disease. Clinically, however, I am not aware of any like genetic testing that is that we currently use for this diagnosis. So causes of secondary RBD, for the sleep people here, this is likely going to be in your sleep boards as well. A vast majority of secondary RBD are going to be related to alpha-synucleinopathies. Okay, and then these are the conditions, and only these conditions are alpha-synucleinopathy. Okay, conditions such as Alzheimer's, dementia, those are actually tauopathies, or those that involve the tau protein and not the alpha-synuclein protein. Okay, so alpha-synucleinopathy would be your Parkinson's disease, Lewy body dementia, multisystem atrophy, and pure autonomic failure. Okay, tauopathies such as PSP, progressive supranuclear palsy, or Alzheimer's dementia. Other causes, as mentioned, would be the narcolepsy. And then important here, and very many times missed is RBD associated with medication, specifically antidepressants. Okay, and there have been some reported with paraneoplastic disorders, such as voltage-gated potassium channel antibody limbic encephalitis, Marvin syndrome. There's MA1 and MA2 autoantibody, and the more recently reported IGLON5 condition, and also the brainstem lesions. So another way of thinking about this, which might have some help in trying to come up with differentials, would be late onset and early onset. And in terms of age cutoff, it's 50 years old. So if the onset is at age 50 or more, it's commonly associated with neurodegenerative disease. Again, more commonly alpha-synucleinopathies. If it's early onset, meaning less than 50 years old, it's commonly related to something like narcolepsy, maybe antidepressant use, or isolated. Again, isolated, idiopathic now, but perhaps if followed long enough, they may develop neurodegenerative condition later on. So this is just a table that I wanted to bring people's attention to. Antidepressants are known to cause or worsen a couple of things in terms of sleep. Okay, one would be something like RBD. Okay, one would be something like PLM, and one would be something like RLS. Okay, I think this is very important for the sleep providers to know, especially our trainees. These, you should be looking at their medication list. Okay, not everything is just snoring and sleep apnea. You guys need to be looking at the medication list. One thing interesting that I saw here, which kind of goes against what I had previously known, is there is reported bupropion. Okay, now this table doesn't break it down that the bupropion alone caused the RBD. This is just a reporting of what patients were taking. So I wonder if the patients on bupropion could be on some other medications as well. Now, why am I highlighting bupropion? Because bupropion, if there's any one antidepressant / anti-anxiety medication that might be an option for, say, RBD or bad PLMs or bad RLS, that would be bupropion, potentially, to have them switch to. Again, that can be a board question. Narcolepsy, most common cause of secondary RBD in early onset, meaning less than 50 years old. About a little over a third of narcoleptic patients had RBD, and actually about 60% of those with cataplexy had RBD. And in a case series, about 38% of early onset RBD was due to narcolepsy. So most common cause, secondary RBD in early onset RBD, narcolepsy. And just a table here, RBD, the common ones would be the synucleinopathies here, as we had talked about earlier, not commonly with something like Alzheimer's or the other conditions, okay? Frequency of RBD in Parkinson's disease has been reported anywhere from 15 to 65%. In dementia with Lewy body, it's higher, it's about 68 to 90%. And with MSA or multiple system atrophy, it's about 60 to 90%. So what do these frequency numbers mean? Well, at least for neurologists, if we have somebody in front of us with these conditions, with these neurological conditions, one of the things that ideally should be asked for would be something like RBD symptoms. On the other hand, okay, if on the sleep part, non-neurology clinic, if you have somebody with RBD, then one of the things that you need to be on the lookout for would be potentially a coexistent neurological condition, which again may or may not be present at that time that you're seeing the patient. So I wanted to just briefly discuss this. This is an elegant study by Dr. Schenk. I believe he is or was a neurologist somewhere in Minnesota. He published this study in the 90s. And basically, this is a longer term follow-up of about 29 patients that initially were thought to have, at that time, idiopathic RBD. Okay. And so what he found, among other things, was RBD patients that eventually developed PD, they had increased PLMs, okay, during non-REM sleep compared to those that stayed as idiopathic RBD. And the stage 3 and 4 slow wave sleep appears to be somehow increased in the RBD with eventual PD population. So I wanted to highlight here, so at that time, 11 out of 29 patients, or about 38%, developed PD. Okay. Now, in 2012, again, that's 1996, and then they looked at the same 29 patients in 2012. Okay. So 29, 3 were lost to follow-up, so they're down to 26 patients. 21 out of the 26 developed Parkinsonism or dementia. And the mean interval to the onset from the RBD symptom to the onset of clinical symptoms of Parkinson's or dementia, it's about 14 years, plus or minus 6. That's a long time. Okay, so that's 38%. And more than 16 years later, it's 81% of these patients. Okay. So both IRBD and secondary RBD have been shown. We've talked about this. The association with alpha-synucleinopathies, estimated risk of developing neurodegenerative disease in idiopathic or isolated RBD, 5 years is about published at least. It's about 17%, 10 years about 40, 12 years it's about 52%. So some clinical pearls in alpha-synucleinopathy disorders associated with RBD. The RBD typically begins years or decades before the onset of cognitive and motor features. Interestingly, the motor control is actually transiently improved during RBD in these patients with MSA as well as Parkinson's disease, and the improvement was present even in the most affected patients. What does this mean? Sometimes we see patients, Parkinson's patients in the neurology clinic, and they can barely talk, and they're just barely whispering when they're talking. Okay, but then when you ask the family, or sometimes the family volunteers this, hey doc, you know what? When this patient is sleeping, he can actually like yell during the night, and to the point that you can hear him from across the hall. So they can have that. They can have improvement in their vocalization, at least transiently during sleep. On the other hand, for the non-synucleinopathy disorder, the RBD tends to evolve concurrently with or after the onset of Parkinsonism or the symptoms. Just some clinical pearls there. RBD screening, there's a couple of questionnaires that I come across with. Typically, I don't quite find this very helpful in clinical practice. I just ask for symptoms, but just know that there are some that are available. The Mayo Sleep Questionnaire is actually available free for non-commercial use. So pitfalls and RBD mimics. This is a table that I found RBD is towards the right here, second from the right. And again, it's later time during REM. EEG is usually fine with that. There's no abnormalities in the EEG. Motor activity would be very high with RBD, and they will typically be anywhere from 1 to 10 minutes, and it's usually in the older age group population. This goes to show as well that, sometimes, actually many times, when patients and families come to you, they will start talking about, or at least what they think are sleep terrors or sleepwalking. They'll come to you, hey, doc, my mom or my dad is having this sleep terror, and it's been happening just in the last maybe 6 months or so. So just be careful with the terminology there. These are actually different things. These are different entities, okay? Other things that might cause what we call pseudo-RBD manifestations would be something like untreated OSA, and then you have, as mentioned, narcolepsy. You can have RBD there, PTSD, and alcohol or drug administration or withdrawal. Pathophysiology, now we're getting into into the weeds here. It's thought to be dysfunction in the brainstem nuclei that modulate REM sleep and the anatomical inputs from other regions. So it's mostly brainstem structures, the nigrostriatal complex, locus coeruleus, and the raphe nucleus, and others. The RBD motor behaviors reflect brainstem impairment, while the frightening dream part of it is usually a reflection of the amygdala dysfunction. So Brack and colleagues have proposed a staging system for the neuropathologic characterization of the phenotype. I actually have a picture, a couple of slides after this, and it might be applicable to the timing of the evolution of RBD in the context of evolving other clinical features of the underlying neurodegenerative condition, but it does not quite explain everything. So in terms of the anatomy, so the primary REM sleep generator is actually in the lateral pons, okay, and then the surrounding nuclei there, like the locus coeruleus and those structures. So those, let's go to the right here. So this is what normally should happen, okay? So the pontine structures stimulate the medullary centers. When the medullary centers, the neurons there are stimulated, they are actually inhibitory downstream. So that should inhibit the spinal cord, specifically the interneurons and the spinal motor neurons. When the spinal motor neuron is inhibited, therefore, it inhibits skeletal muscle activity. That's what should happen in normal REM sleep. Okay, so that is what we call the REM-associated atonia. No tone during REM. That is normal. Okay, now what happens is if you have a problem anywhere in this pathway for whatever reason, okay, there is a lack of that stimulation of the medullary center. And if that is not stimulated, therefore, the downstream inhibition may not necessarily happen. And so therefore, the end result of that is your skeletal muscle is not quiet, it's not inhibited. So you have lack of REM atonia. Okay, so this is a simplistic, and this is the most simple diagram that I've found to try to explain REM behavior disorder anatomically. So in terms of pathophysiology, so this is the work of Brack. This is the slide I was mentioning earlier. So for non-neurologists, you guys may or may not have seen this before, but basically what this is, on the lower left corner here, there's like stage 1, 2, 3, 4, 5, 6, right? And then as you go up, it involves like different areas of the brain. And basically what this is during the early pre-symptomatic phase of the underlying neurodegenerative condition, only certain structures are affected. And as the condition progresses, as more brain structures are involved, it then hits a clinical threshold. And once that clinical threshold is hit, then the patient now starts becoming symptomatic. You might see at that time, shaking in the hand, tremor, or maybe dementia symptoms, those kinds of things. Having said that, RBD happens early on. Okay, here in the lower left quadrant, you see this dorsal motor 10 nucleus. This is, the black area here in the brainstem and the red area. These are where the RBD pathology is thought to start. And then it kind of like over time, it involves other structures, eventually going up into like the midbrain, the thalamus. And that's when you get like the clinical Parkinson symptoms when the midbrain gets involved with the red nucleus, substantia nigra, and then it goes up to the cortex, and you get all the other manifestations. We'll skip this. All right, in the home stretch. So treatment of RBD may be required for the following reasons. One is prevent injuries in patients. Also to avoid disturbing the bed partners, quality of sleep, or prevent injury for bed partner as well. And to decrease the intensity of unpleasant dreams for those subjects disturbed by this uncomfortable experience. So what do we have to tell these patients and their families? Try to maintain a safe sleeping environment. Okay, that means maybe clear the sleeping areas of sharp edges and objects, the corners of nightstands, those kinds of things, scissors, knives, guns, alarms, bed alarms, physical barriers, bed rail and gates, okay, or maybe even a separate sleeping area. Sometimes by the time patients come to you, they've already figured this last part out. They're already sleeping in maybe another bed or sometimes even another bedroom. Then there can also be the bed alarm systems. I mean, these are not any different from the ones that are used in the hospital, like for patients who might be like delirious and might be wanting to get up and like wander around, which can lead them to fall. So there are bed alarm systems available as well. Now, as I had mentioned earlier, there are no FDA-approved treatment that exists for this condition. This is a list that I found of evidence-based therapy. Again, these are not FDA approved specifically for RBD. The most commonly used, I would say, would be clonazepam and melatonin at the suggested doses here. Having said that, you're going to have to look at potentially, some of the considerations. Again, many of these patients tend to be older. Many of them might already have like cognitive issues. And so for those patients, I may want to start perhaps on something like melatonin, see if that helps before I jump into something like clonazepam. Okay, and you've got to be aware of drug interactions, risk for falls, and other side effects. There have been other medications that are reported. Personally, I don't think I have used any of the other things. Some of my patients are already on rivastigmine just because of their underlying Parkinson's dementia symptoms. But these are some of the other reported evidence-based, not FDA approved, but evidence-based pharmacotherapy. So when I was preparing for this, I actually stumbled upon this trauma-associated sleep disorder. I don't know how recent this is, but this seems to be recent enough. I don't remember having seen this during fellowship. It shares the diagnostic criteria for RBD. The proposed diagnostic criteria for this condition, there is usually some sort of inciting traumatic experience. The altered dreamentation is usually related to the prior traumatic experience. So it's actually like PTSD like. And then you have the report of dream enactment behavior. Then there's autonomic hyperarousal or monitoring that demonstrate tachycardia, tachypnea, or diaphoresis, not due to, say, like an underlying OSA. And then you have PSG evidence of pathology and absence of like EEG epileptiform activity on the sleep study. Have I diagnosed something like this? No, but I thought this was something recent, and I have not encountered this before. All right, so this is the last part with the controversies and ethics in RBD. So the question here, or the dilemma here is, you know, RBD, in as much as it is a diagnosis, as we have discussed, it actually can have a downstream risk of something else. And that something else is what? Potentially neurodegenerative condition. Okay. So this is a nice article that I have found. This was from 2013 in one of our neurology journals. But basically, there's pros and cons. There's arguments against disclosure and arguments for disclosure. Some of the arguments against is, well, we don't know when the neurodegenerative disease will actually develop. Okay, and anxiety and needless worry in anticipation may happen. And then again, there's no treatment that currently exists to stop or delay the progression. And then on the other hand, on the flip side, the arguments for disclosure, the patient may want to know and want to have some informed decision, seek second opinion, maybe prepare for the future, watch for symptoms. And one of the risks there is, withholding may harm the patient-physician relationship because at least, especially in this day and age of trying to look up things online, the patient at some point will learn about risk sooner rather than later, or sooner or later. So this article basically says, whether to break such news to patients is not the question. The question usually is, when and how do you break the news? Early disclosure appears to be the best approach rather than waiting until symptoms develop. But then again, how early? This is probably something you don't want to be sharing on the first visit. Okay, maybe in the second, or maybe in the third, or maybe later. Okay, this might just depend on the individual patient. Gauge patient readiness and ask if patient wants to know. When patients were asked, for their preference toward receiving prognostic information, actually a vast majority felt that knowledge concerning the neurodegenerative disease risk was important. And they felt that the discussion about prognosis was actually important to maintain the trust in their physician. A good 95% indicated they wanted more information, and only about 4% would have desired less information. Okay, so what does this translate to? I mean, in the sleep clinic, especially for non-neurologists, I mean, we don't expect you to be diagnosing Parkinson's and like MSA and those kinds of things, even for general neurologists, that those can be tricky to diagnose, or outright, there can be misdiagnosis there sometimes. But the take-home message here is that, think beyond what is in front of you. Think beyond just the sleep apnea. Think beyond the RBD, and maybe have that discussion with the patient about this risk of neurodegeneration. And if the patient is already maybe having some questionable symptoms, maybe at that time that would be a referral to a neurologist, okay, for diagnosis and then maybe management of the underlying, condition. We're done. So in summary, RBD diagnosis requires clinical correlation with PSG to confirm. It can be isolated, formerly called idiopathic, or it can be associated with other conditions. There's a strong association between alpha-synucleinopathies and RBD. RBD diagnosis potentially has implications that go beyond just a sleep nuisance and danger to sleep and others. And it is recommended that patients with RBD be made aware of the risk for developing neurodegenerative condition at some point. Thank you. Any questions?